Hepatic trauma can be either blunt or penetrating trauma, and eventually it will lead to intraparenchymal laceration or sometime in a form of hematoma. This could happen underneath the capsule or in pericapsular region or subcapsular region in the form of hematoma or capsular rupture sometime with associated intraperitoneal hemorrhage. So these are all the consequences of the hepatic trauma, leading to either laceration or hematoma or sometime intraperitoneal hemorrhage. So for the detection of this hepatic trauma and its grading, we usually need radiological imaging including ultrasound, CT scan, contrast and non-contrast scanning, angiography and MRI. But MRI is not useful, it's rarely used. So far the benefit of the ultrasound and CT is concern is much more wider in hepatic trauma. So let's start watching these images, how this hepatic trauma will appear on the ultrasound imaging. Ultrasound imaging is more useful for follow-up rather than for the diagnosis. This is ultrasound image, transabdominal ultrasound has been performed on a patient having a blunt trauma. This yellow arrow indicating echogenic area, which is suggestive of hemorrhage, but beside this small patchy area can also be seen, which suggests laceration. So this is a clear example of internal intraparenchymal hemorrhage, mild hemorrhage associated with slight laceration. However, clear hematoma could not be easily distinguished, but a echogenic line showing that there is significant hemorrhage in the intraparenchymal area of the liver secondary to blunt trauma. In the trauma section, this patient been through examination, ultrasound examination revealed intraparenchymal bleeding. This yellow area indicating intraparenchymal bleeding. Hemorrhage always appear as echogenic as it is parenchymal hemorrhage. That's why within the liver you can appreciate patchy echogenic area suggestive of hemorrhage. However, you cannot appreciate hematoma there because this is an early stage and still this blood is not liquefied, it's still there and it's not reabsorbed, so that's why it appears an echogenic. So in this case you need to look for the subcapsular or pericapsular region, because quite often you will see some laceration or subcapsular hematoma in that condition. This is another post-traumatic ultrasound scan. Post-trauma injury shows intraparenchymal hemorrhage. Patchy hemorrhage can be seen because of increased echogenicity in the liver, but this yellow arrow is indicating intraparenchymal hematoma as well. So now this blood has been liquefied. Because of that, this hypoechoic area can be picked. So this is actually hematoma, and this would be considered as parenchymal, intraparenchymal hematoma. In that case, whether the trauma is blunt or penetrating trauma, you must look for the intraparenchymal hemorrhage, laceration or subcapsular hematoma or subcapsular laceration. In another example of intraparenchymal hematoma, this is quite clear and you can easily pick that, and a surrounding area still shows some level of hemorrhage. This is the right lobe of the liver and this is transabdominal scan, and this facility is available in the post-traumatic emergency unit. So in post-traumatic emergency unit, if you are working, so you can use the ultrasound, and ultrasound is a reliable, easy and fastest scan to pick the intra-abdominal bleeding, internal organ ruptures, hematoma or laceration, because it's a reliable tool, quickly available and easy to approach. Therefore, always depend upon the ultrasonography so far its prognosis is concerned and so far its follow-up is concerned, because it will help you to identify to what extent hematoma has been resolved and to what extent this hemorrhage has been absorbed. Plain CT scan is one of the important tool in the trauma section, in trauma emergency section. So when the patient's been through any penetrating trauma or blast or fire injury or any road accident, the CT scan will help you out to rule out any internal organ damage, internal bleeding, body or organ laceration or hematoma. Look for these 4 images. In these 4 images, on the topmost, the white arrow showing small area of hematoma, and in the consecutive image on the upper part, on the top upper region of the towards the left side, you can also appreciate the same, while in the lower both images you can see that these hematoma has been slightly extending and increasing in size because of its liquefactive content. So this is hematoma on the CT images. This is another axial scan of the CT, and on this scan you can appreciate well defined large hematoma. This is actually a big hematoma, intraparenchymal hematoma. This is a surgical candidate. Beside this, there are other patchy area of hematoma can also be seen. These hypodense area suggestive of hematoma. So this hematoma has already been liquefied and it needs further attention because of these liquefactive hematoma. There may be a lot of complications which will eventually lead to either abscess formation or gangrene or ischemic. So it needs surgical attention. It need to be cleared up surgically. Another CT axial image, a classic example of pericapsular and subcapsular hematoma. So you can see all the length towards the right side or the right border of the liver is showing hypodense area, indicating by the head of black arrows. So this is called as subcapsular or pericapsular hematoma. As far as other part of the liver is concerned, that is normal and there is no intraparenchymal bleed, but so far the internal area where the gallbladder is usually happens, you can appreciate that there is still intraparenchymal bleeding as well. So 2 findings you can appreciate: intraparenchymal hemorrhage beside pericapsular and subcapsular hematoma. So these 2 are the findings. If you look for the liver is enlarged and it's more towards the left side. So hepatomegaly with the pericapsular and subcapsular hematoma and intraparenchymal hemorrhage. This is another axial slide, and in this axial CT image you can appreciate a well defined hypodense area on the right lobe of the liver, extending from the capsular region towards the intraparenchymal area. So pericapsular hematoma can be seen here. As for the upper border of the right and left lobe is concerned, you can appreciate a small linear hypodensity as well. So it's mean all the way around through the capsular, in the pericapsular region there is hematoma, and extension of the hematoma can be seen all around. So this is another example of hematoma. Angiography is only required when there is continuing hemorrhage or suggesting a major vessel laceration of a degree that it is not immediately life threatening. If it is life threatening, so obviously no need to waste the time on angiography, straight away operation and surgery is required. But if it is not life threatening and there is hemorrhage, so it need an angiography to find out where exactly the source of bleeding. It can identify the source of any bleeding and permits embolization. So you can apply the treatment methodology, and that would be embolization. So therefore angiography is required in those conditions where there is hemorrhage, but not to an extent where it causes life threatening. If the liver trauma is not treated properly, it will lead to certain complication. The first complication is ischemia, which eventually leads to necrosis, whether it is lobular or any segmental, but there is likely chance of ischemia and necrosis. The second chance of complication is abscess formation. there will be abscess formation, which is quite common post-trauma condition. That's why follow-up scans are very important. Hemophilia, obviously this is usually seen in blunt trauma. If there is blunt trauma, there is likely to have the ear within the portal veins or within the vascular structure. Focal fibrosis is likely occur. Calcification, post-traumatic calcification is common. If you see any calcification in post traumatic patients, so that would be considered as benign. Lobar or segmental atrophy secondary to trauma, this is another complication of hepatic injury. Now come to the very important point, that is CT injury grading scale, because grading scale helps the management and it will help to manage the patients properly. So these CT gradings has been divided into 5 grades. So grade 1 is when the laceration is less than 1 centimeter deep and subcapsular hematoma is less than 1 centimeter in diameter. This would be considered as grade 1 injury. Grade 2 injury would be considered when the laceration is 1 to 3 centimeter deep and subcapsular or central hematoma would be 1 to 3 centimeter in diameter. That would be called as grade 2 injury. In grade 3 injury, there will be laceration 3 to 10 centimeter deep, while subcapsular or central hematoma would be 3 to 10 centimeter in diameter. Grade 4 injury would be considered when there is more than 10 centimeter deep laceration. Subcapsular or central hematoma is more than 10 centimeter in diameter, but beside these 2 points, there would be lobar laceration or there may be devascularization. So this would be considered as grade 4 injury. Grade 5 injury is serious in nature. There will be bilobar tissue maceration or there will be bilobar devascularization. So this would be grade 5 injury.